Hi everyone. In this webinar, I'm going to be talking to you about a project on forecasting and optimization for a nursing resource team. I'm Neal Kaw, a data scientist at CHART, and this is work I completed jointly with my colleague Josh Murray, also a data scientist at CHART. First, I'll explain some of the background to this problem. St. Mike's Hospital created its NRT in April of 2017. The NRT is a team of nurses who are not permanently assigned to any nursing unit in the hospital. Instead, the NRT's role is to fill short-term nurse absences in the inpatient units, the emergency department, and the ICUs. The way the process works is that anytime any of the nursing units becomes aware that any of its nurses are going to be absent for whatever reason, it may be vacation, education leave, sick leave, and so on. Whenever this happens, the nursing unit will contact the NRT and ask them if there's an NRT nurse available to fill that shift. If the answer is yes, then the NRT nurse will be temporarily assigned to that nursing unit. The answer may be no, and in that case, there are two other alternatives available. The nursing unit may arrange for one of its nurses to come in for an overtime shift, or it's also possible that the nursing unit will arrange for a temporary nurse from one of the nursing agencies that St. Mike's works with. Part of the NRT's goal at St. Mike's is actually to reduce the reliance on overtime and agency shifts. And part of what that will achieve is a reduction in our total nursing labor costs, because overtime and agency nursing can cost 50% or more than the regular wages that are paid to NRT nurses. This brings us to the problem that CHART was engaged to work on. The decision that needed guidance was, how many full-time equivalent nurses, or FTEs, should the NRT have? In other words, how large should the NRT be, given that the primary objective would be to minimize the total cost of staffing short-term nursing absences in the hospital. This is a schematic diagram based on dummy data, which gives some of the intuition underlying the problem. On the x-axis of this plot are the total number of NRT nurse FTEs, and on the y-axis is cost. I'll go through each of the curves on the plot one by one. The purple line represents the amount of NRT wages, and this amount would increase linearly as the number of FTEs on the team increases. The red and green curves represent the total of agency costs and overtime costs respectively. We would expect these costs to decrease as the size of the NRT increases, because NRT nurses would be able to cover some of those shifts. Beyond some point, we would start to see diminishing returns, because there would be a point at which the NRT becomes large enough to fill virtually all nursing absences. And beyond that point, we would start to see very little reduction in the agency and overtime costs as the NRT size increases. The blue curve is the total cost, the total of the other three curves. This curve we can see shows a decrease in the total cost as we increase the size of the NRT from 0. We would then reach some optimal cost minimizing point, and that is marked by the yellow square with the X in it. And beyond that point, we would expect to see the total costs of short-term staffing to actually increase, because we would be adding FTEs to the NRT without having an appropriate number of absences to keep those nurses occupied. So the question we would be trying to answer is, what is that number of NRT FTEs which achieves our minimum optimal cost? There's one more dimension of the problem which I haven't discussed yet, and this is the fact that nursing in the emergency department or the ICUs actually requires a critical care certification, and getting that certification for a nurse requires enrolling the nurse in an 8-month certification course. So a more refined problem statement actually reflects that there are two decisions which need to be made here. First of all, how many NRT FTEs should there be? But secondly, among those FTEs, how many of them should have the critical care certification? The primary objective would still be to minimize the total costs of short-term staffing, but this total cost would not include the training cost of enrolling nurses in the certification. This was a decision we reached in consultation with our project partners, and the reasoning behind this is that training is considered a longer-term investment in our nursing workforce, whereas this problem is focused more on minimizing the short-term operational costs associated with staffing absences. This is another schematic plot based on dummy data, which gives some of the intuition for the problem when we take into account the critical care certifications component. As before, the x-axis still represents the total number of NRT FTEs, and the y-axis is total cost. Each of the curves on this plot represents the situation we would have at different numbers of critical care certified FTEs. For example, the uppermost curve on this plot, the blue curve, represents the total cost we would expect to see when 0 members of the NRT are certified in critical care. As before, the cost would decrease to some optimal point and then begin to increase. Now, for example, the second curve below that represents the situation where, hypothetically, if we had 10 FTEs on the NRT certified in critical care, what the cost would look like. We would expect to see a decrease in cost across the board because those 10 FTEs would be able to cover requests which previously the NRT would not be able to cover with 0 certified nurses. We would also expect to see that the optimal total team size would increase. And the reason for that is the addition of critical care certified nurses would essentially make it possible for the NRT to start filling a greater total number of requests. Similarly, as we would increase the number of certified FTEs to hypothetically 20 or 30, we would see decreases in costs and an increase in the optimal total NRT size. So the question we would be trying to answer here is, for each number of critical care certified FTEs, what is the total number of NRT FTEs that would minimize total cost? The methodology we used to solve this problem consisted of 2 parts. First, a demand forecasting module was used to forecast the number of absences for both nursing skill levels. Second, an optimization module took the forecasts as input and used them to determine the optimal number of NRT FTEs to minimize our total cost. To summarize the demand forecasting module, the data that this module took as input came from St. Mike's payroll system. It consisted of all nurse absences from November 2014 until March 2018, a period of just over 3 years. The output produced by the demand forecasting component gave us the predicted weekly number of missed nursing shifts in the fiscal year 2018-19. And these predictions were produced separately for both nursing skill levels and for different categories of absences, such as vacation shifts, education leave, sick leave, and so on. The method of forecasting was actually the average of 3 component models listed there on the slide. The results that we achieved with these models gave us accuracy of 90% or higher on our test sets. To give you a sense of the data analysis that went into the forecasting, let's look at some example plots. The plots on this slide all correspond to the historical absences due to vacation. On the upper left, this plot shows us that the volume of absences due to vacation tends to be higher on days immediately following a holiday as compared to all other days in the calendar year. The plot on the upper right shows how absences due to vacation tend to vary by day of week. Here we can see that the volume of absences tends to be somewhat lower on the weekends as compared to weekdays. The plot on the lower part of the slide shows us how vacation volume varies by week of year. There are a number of peaks and troughs we can immediately see. The highest peak occurs in July and August. There's also a peak that occurs in December. And there's also a third peak, which may be less obvious. That's week 11 of the year, which actually corresponds to March break in Ontario. On this slide, we can see an example forecast. This forecasting model was applied to the total of all vacation shifts. Along the x-axis is the week number of the year, and it goes from 0 to beyond 150 because it represents all 3+ years in our data. The red time series corresponds to the historical number of absences due to vacation in each week of the year. The black time series represents the number of absences due to vacation predicted by our forecasting model. The vertical black line separates the training and the test set. In other words, the data to the right of the vertical line was not shown to our forecasting model during training. So in this part of the plot, we can see how well our forecasting model performs against the historical data. And with the exception of a few peaks and troughs, we can see that overall, the forecasting model does capture the pattern of absences. The demand forecasting component of the model produces in each week over the planning horizon the predicted number of nursing absences that we would see in the hospital. These forecasts are then fed into the optimization component of the model. Mathematical optimization in general does the following. It identifies values for a set of decision variables which minimize or maximize some objective function. In the context of the NRT problem, the optimization we defined had these characteristics. It had decision variables representing the number of NRT FTEs at each skill level, but it also had decision variables representing the number of overtime and agency shifts which would be necessary in each week at each skill level in order to fill the requests which the NRT FTEs alone would not be sufficient to cover. The objective function was to minimize the total of the NRT salaries plus the agency costs plus the overtime costs. In addition to the demand forecasts that we discussed earlier, the optimization model also takes in 16 other input parameters. These input parameters correspond to various aspects of the NRT staffing and scheduling process as it actually occurs in practice in the hospital. For example, some of these parameters include the average hourly wage for an NRT nurse, or the average hourly rate which has to be paid to an agency nurse, or the average number of shifts that a single NRT FTE would be expected to be able to fill in a given week. All of these various input parameters, wherever possible, are estimated based on historical data. However, there's uncertainty associated with all of those inputs. In particular, some of those input parameters might be expected to have their values change in the future. Because of this problem, what we did is we developed a graphical user interface, or a GUI. The function of the GUI is to allow the user to modify the values of those 16 different input parameters and to observe how the optimal solution of the optimization problem changes in response. I'll briefly demonstrate how the GUI works. This is the interface here. What we can see on the left side of the panel are all of the various input parameters that go into the model. I won't go through all of them one by one, but currently all of them are set to their default values. What we can then do is click Run Optimization, which runs the model for the inputted values of the parameters on the left, and generates these outputs on the right side of the panel. The first output we get is a cost plot, which has the same format as the schematic diagram that I showed earlier in the webinar. Along the x-axis are the total number of NRT FTEs, and we have cost curves corresponding to different numbers of critical care certified FTEs. What we can see here is that the model estimates at the default values of the input parameters, the optimal team size would be approximately 38 FTEs, with 15 of those FTEs certified in critical care. What we can now do is see how the solution would change with different values of the input parameters. For example, this input parameter here on the lower left is the hourly agency cost for a general nurse. It's currently set to 60, which is the rate that St. Mike's does currently pay for agency nurses at the general skill level. Now let's see what would happen if hypothetically in the future that hourly rate increased to $70 per hour. We can rerun the optimization model. And what we see is that the optimal team size has not changed much. It has bumped up slightly closer to 39, but not a big difference. Let's see what happens if we change a different input parameter. On the upper left, this parameter corresponds to the average number of available shifts for one NRT nurse FTE per week. Currently, it's set to 3.01 as the default value. Let's see what happens if that weekly number of shifts was decreased to 2.8. What we can see is that the optimal number of NRT FTEs has actually increased up to around 41 FTEs, and the optimal number of critical care certified FTEs has increased to 16. By iteratively rerunning the model with different sets of input parameters, the decision makers in the hospital can gain a sense of what the reasonable ranges would be for an NRT in the hospital. So to briefly summarize what we've done in this project, first, we developed time series forecasting models for nurse absences in St. Mike's Hospital. They predict the weekly number of absences that we would expect to see at 2 different nursing skill levels. We then formulated an optimization model which takes those demand forecasts as an input and outputs the number of FTEs for the NRT at each skill level such that the total cost of staffing short-term absences is minimized. We then designed an interactive tool which enables decision makers to observe how the optimal solution changes in response to different values of the input parameters for the optimization model. The purpose of a tool like this is to allow the decision makers in the hospital to develop a sense of what the reasonable ranges would be for the size of an NRT at St. Mike's. Tools like this can be used broadly to help support evidence-based decision-making in the hospital operations. Thanks for watching.